IOL scaffolding, a virtual barrier to prevent posterior capsular end and to prevent endothelial damage. Anand Eye Hospital presents author Dr. Sonu Goyal. None of the authors have any financial interest in any of the products. The concept: the intraocular lens acts as a scaffold to prevent a nucleus drop in a posterior capsular rupture during the phacoemulsification surgery. It can also help in removal of silicone oil without damaging the endothelium of the cornea. The signs: the nucleus is emulsified above the IOL very safely without any of the pieces falling in the vitreous cavity. The IOL keeps the vitreous in place. The IOL prevents the vitreous prolapse in the anterior chamber, and it decreases the hydration of the vitreous from the fluid. This also prevents the direct contact of silicone oil with the posterior surface of cornea. So the basic concept is the IOL giving a support during the phacoemulsification surgery. As you note here, during the cataract surgery, the surgeon realizes a posterior capsular end with a small amount of vitreous prolapse. The nuclear fragment is gradually, the last piece is brought in the anterior chamber, viscoelastic is injected, and the hydrophilic acrylic foldable IOL is gradually pushed in the sulcus. Note is made that the leading haptic goes in the sulcus while the trailing haptic rests over the iris. So this basically acts as a support to prevent this nuclear fragment from falling into the vitreous cavity, and this nucleus can then be emulsified. Care should be taken that the parameters are low, and good viscoelastic should be supplemented in between to prevent endothelial cell damage. Once the nucleus is emulsified, this IOL can then be either dialed into the bag if there is no lens matter, or it can be then brought in the angle, and lens matter can then easily be aspirated out using either a bimanual, as you see here, bimanual irrigation aspiration. Care should be taken that the vitreous prolapse or the vitreous has not to be pulled, and a good vitrectomy, anterior vitrectomy, should be done if there is any vitreous prolapse in the anterior chamber. We see here there is a posterior capsular end. So after clearance, the lens is being dialed, and very safely a good surgery can be accomplished. This is yet another case where during the surgery we realize that there is a posterior capsular breach. The nuclear fragments are brought into the anterior chamber, and this hydrophilic acrylic foldable is then gradually pushed in. Care should again be taken that the leading haptic goes in the sulcus and the trailing haptic sits on the iris. So this prevents these nuclear fragments from falling off into the vitreous cavity. The anterior chamber has to be full with the viscoelastic and repeatedly supplemented so that there is no endothelial cell damage. If you see clearly, the lens is being emulsified and the IOL is acting as a barrier to prevent the vitreous prolapse. So this was a hypermature Morgagnian with hard cataract. If you see here, even the capsule dials, the capsule is shaky. So with weak zonular support, such patients can easily be managed. Yet another case where we realized that the whole bag was shaky and it was moving. So the nucleus was brought down in the anterior chamber and the lens was pushed in and made to sit in the sulcus. So this IOL would then prevent the weak capsule to bulge into the anterior chamber. A good viscoelastic is made to fill in the anterior chamber, and this lens is then emulsified in the anterior chamber. Care should be taken that there is no endothelial cell damage. Viscoelastic should be supplemented on a regular basis, and careful phacoemulsification can then be carried out in such patients. As you can see here, this patient had a very bad cornea with a central band-shaped keratopathy. So despite all odds, a successful phacoemulsification can be managed and good vision can be restored in such patients. The band-shaped keratopathy becomes now quite obvious, and the lens matter can be taken up and the IOL sits in the sulcus. The ports are sealed and the AC is then formed. Yet this is another case of a vitrectomized eye with silicone oil and secondary cataract. We go in, push in viscoelastic, drain out the silicone oil in the anterior chamber and try to accomplish a good rhexis. So we initiate our rhexis, make a 2.5 main port entry, and looking to the weak zonules, we try to push in a capsular tension ring to support the weakened zonules. The ring should be put in very delicately, and a phacoemulsification is then carried out very carefully, giving least pressure on the weak zonules. So after the emulsification, the lens matter is gradually aspirated out. You can see here the silicone oil all behind the capsule, and a hydrophilic acrylic foldable eye oil is then injected into the bag. Viscoelastic is placed behind the eye oil to accomplish a posterior capsular rhexis. So using a 26 gauge needle, initiation is made, and this posterior capsular rhexis is then being done under the IOL using a micro rhexis forceps. And how beautifully a rhexis is accomplished. This IOL can then be brought anteriorly in the anterior chamber, and the silicone oil is then gradually removed from the main wound. By this technique, 12 eyes of 12 patients had undergone IOL scaffolding, and one of the patients underwent cataract surgery with silicone oil removal. The mean post-operative visual acuity, the best corrected, was 0.91 plus minus 0.15. The post-operative 20/20 vision was achieved in 70% of the patients. So this method is safe to handle intraoperative complications and prevents nuclear fragment drops. Silicone oil can also be removed safely. Thank you.